Yeah, welcome to the panel discussion on neurophysiology and mechanism of action of local anesthetics. You would have heard the presentation by Dr. Ramakrishna Shenoy, and now let us take the discussion a little more deep by discussing few pertinent questions regarding neurophysiology. Now, for the discussion, we have Dr. Elavenil, Professor, SRM Dental College, Department of Oral Maxillofacial Surgery, and Dr. Sneha, who's the professor at Savita Dental College in Oral Maxillofacial Surgery. So let me, I think Dr. Shenoy's presentation was very exhaustive, but still nothing like having a discussion for easy understanding of the participants. And what are the factors? My first question would be what are the factors that would enhance or prolong the duration of action of local anesthetic agents? Maybe Dr. Elavenil can go
the
first.
First thing would be the characteristics of the local anesthetic agent itself, which is the protein binding capacity of the local anesthetic agent. So if the binding capacity is more, we're going to have more. The local anesthetic molecules are going to be bound to the receptors which guard the sodium channels. So the duration of action is going to be more prolonged. The other major attribute which would decide on the duration of action would be the additives which go into a local anesthetic solution. The main thing would be the vasoconstrictors which are added. So addition of any vasoconstrictor would automatically prolong the duration of action. That has a major role and practically more important. Apart from these, the patient factors would also be one of the points of concern, because if the patient has it need not be a pathological change, it can even be the anatomical change. The area where you're going to inject the solution, if it is richly vascular, totally perfused, the duration of action is going to be lesser. And if it is a pathological change, it's going to be more. The duration of action is going to come down more because the molecules would get cleared away really fast.
Yeah, that's a very clear answer to the question, and that takes me to the next question. Can you speak about the alkalinization of local anesthetic?
So alkalinization is a very novel concept which basically works on the principle of improving a local anesthetic agent's pH. If you all have observed the lecture, you all would have noticed that Sir would have explained about the factors which go, especially the pH, which go into determining the number of base molecules which occur as in the solution, in the local anesthetic solution. And I'm sure you all would remember that we need more of base molecules to perfuse through the nerve membrane and to exert the local anesthetic effect. Now, what happens in a patient where there is too much of infection around the tissue? The pH of the tissue automatically goes down. Now, when you perfuse local anesthetic solution into that area, the number of base molecules which are very, very important to go across the nerve membrane for the local anesthetic effect automatically comes down. So, our objective must be to improve the concentration of the base molecules. Now, alkalinization is one method which does that. It is usually done with the help of sodium bicarbonate, 8.4%. We add about, let's take the ratio is for 20 ml of local anesthetic solution, it's 2 ml of sodium bicarbonate solution. So, the normal multivial bottles that we all use for injection is a 20 ml multivial bottle. So, if you add 2 ml from the ampule, or sodium bicarbonate comes as a multivial bottle also. So, you take 2 ml of that solution, put it into your 20 ml multivial bottle, you have your buffered mix. And then you can withdraw the solution as what you normally do and improve the local anesthetic effect.
And would you like to show how it is done?
So, generally, one of the flip side of adding 2 ml of the sodium bicarbonate solution into the multivial bottle is that you have to use it immediately. Because once a solution is alkalinized, it has a tendency to get precipitated. We wouldn't want that. We want to use it for more number of days depending on the number of your patients. So the other option that we have, instead of turning the whole solution into a solution of higher pH, we can use in increments. So this is the 2 ml syringe that we normally use for delivering your local anesthetic technique. So this would contain 2 ml of your local anesthetic solution, which you have drawn from a multi-vial bottle. So this has 2 ml. And then you can use a 1 ml syringe. Now this is a 1 ml syringe. You can draw 0.2 ml. It is graduated as 0.1 ml and 0.2 ml and so on. So you will withdraw 0.2 ml from the sodium bicarbonate solution. And having withdrawn the solution, you can inject it into the 2 ml syringe. And that is all. You have your, and mix. This is the solution that you need to infuse. And this works wonders. Now this is for the normal syringe, what is commonly used in the Indian scenario. Now if you were to use a cartridge like this, now this comes as a pre-filled vial. This has about 1.8 ml of solution. So how do we infuse sodium bicarbonate into this? Again, the solution is very simple. Use a 1 ml syringe, draw 0.2 ml from your sodium bicarbonate solution vial, and all you have to do is insert it into the diaphragm here and inject it into the solution. And once you have increased, already this was holding only 1.8 ml. Once you have increased the volume of the solution, automatically you will see that the plunger, the stopper that you see at the rear end of the cartridge would automatically go out because the volume has increased with the addition of sodium bicarbonate solution. And then your solution is ready to use.
Thank you. That was a fantastic explanation. Yeah. You would like to add anything?
No,
to okay. Yeah. So now that we have discussed about
one more I could add. Sneha, you were mentioning about the automatic mixers that we have.
Yeah.
Now, when we were discussing, you mentioned that. So we have this mixing. Manual mixing does take some time. So we have these very sophisticated gadgets available in the market, a few of them Onset and Nutra. These are the brands available in the market. These are automatic mixers. All you have to do is put the local anesthetic solution and the bicarbonate solution into the respective receptacles, and the machine does the mixing for you automatically. And all this happens within a matter of few seconds. So you save a lot of time mixing.
Yeah, but then how long, what is the shelf life of this mixed?
They have to be used immediately, sir. That's the flip side.
Yeah,
yes.
Yeah. Thank you. And having discussed alkalinization of local anesthetic, what is the effect of local tissue pH on onset of action of LA?
Okay. When the tissue pH generally starts to drop, as in case of inflammation, the number of base molecules that are available to diffuse into the tissue become lesser. So only if we have adequate 4 nodes that need to be blocked, for that adequate volume of base molecules have to diffuse through the nerve. So this dissociation of the lignocaine hydrochloride into lignocaine and HCl, H plus component becomes more retarded as and when the pH tends to fall. So that is the reason why instead of using LA with epinephrine, which has a lesser pH, we can still go in for usage of a plain LA.
Correct.
But the problem with the use of plain LA is, again, it is a vasodilator, so the profoundness of anesthesia is compromised, and also we know that the area is more perfused because of inflammation, so it is also absorbed into circulation faster, so the duration automatically comes down. So that is where the idea of either using a block or alkalizing the LA would be beneficial.
Yes.
Yeah, it's again neatly explained. And what is the choice of local anesthetic in pediatric population? Is there any specific choice or
the pediatric population, the minimal the pricks, the better it is. So if we have something that will diffuse through the bone with just one single prick, then that would become the choice. So technically, I think that's why articaine is more being used commonly in pediatric population.
It's very
Because
popular.
because the diffusion, bone diffusion is much better with articaine. So even with the buccal penetration, we have adequate amount of anesthesia to facilitate pediatric extractions.
So you prefer articaine over,
Liquid.
but then how do you, I mean, do you get articaine in multiple vials or
No, it comes
the
in a cartridge.
cartridge?
Yeah, that's why we should learn to use
The cartridge.
metallic syringe. Yes,
Yeah.
the reusable metallic syringe.
So, is there any specific reason that we don't get articaine in a multi-use vial, or you get it only in a single-use cartridge?
The only reason that I can think of is probably they wanted to do away with the methyl paraben.
Okay.
That I feel is one of the reasons,
Okay.
because these cartridges do not have methyl paraben,
They
because
also-
it's a single use cartridge.
Yeah.
We don't
and-
have to store them at all.
And
yeah.
they also will not have sodium metabisulfate because you don't open the cartridge and leave it open.
Yeah,
And
it doesn't-
oxidation of epinephrine is never an issue when we use a cartridge. So probably
And so you would advise use of cartridge over multi-use
multi-use
vial
vials.
Absolutely.
for various reasons. One is cross contamination.
That's a very important point that you brought about, sir. Yes. Cross contamination is a major concern with multi-vial bottles.
Yeah.
We should move more towards the single
Use of
use
cartridge.
cartridges.
So what is spotted anesthesia? What do you have to say about spotted anesthesia?
See, the thing is, when we deposit LA near the nerve ending or the nerve fiber, it diffuses through the peri, epi, and endoneuriums, and then it reaches the axon so that it blocks the nerve. Now, if we do not deposit adequate volume of anesthetic, we will have when we look at the nerve, it is in multiple fascicles, multiple bundles that are enclosed in the epineurial sheath. So when the LA starts to diffuse, the outer bundles, which are called the mantle bundles, they will get anesthetized. Whereas the core bundles, which are on the inner aspect of the nerve trunk, they don't get anesthetized. So when the nerve starts to travel along the ion canal, the outer bundles, the mantle bundles, they will start supplying the molar teeth. But as and when we reach the canine area, where the core bundles, the canine and the lateral incisor area, the core bundles are the ones that are supplying. So those areas will not be anesthetized because the LA hasn't diffused till the core of the nerve. So that is the reason why we will have anesthesia in the molars, but as and when we come more away from the nerve, more distal from the nerve, the canine and lateral may not be anesthetized. That is why we are always taught that when you check for your anesthesia, always go and check near the canine premolar region so that we know that you have deposited adequate volume and the whole trunk is numb. And we don't always check in the region of central incisor because central incisor will have a contralateral supply.
Yes.
So cross innervation is there, so that is why you cannot check. So this is the concept of spotted anesthesia. So when we learn all this, we do understand that, everything as far as depositing a local anesthetic is important. Anatomy, volume, what are you using, how are you using,
the target area.
area, all of these become important.
That is why it is also called as patchy anesthesia, because you
Patchy
have
anesthesia.
anesthesia in patches, not throughout and profound.
So that leads me to the next question. You're talking about the cross innervation of the central incisor. So if you are doing a procedure in a central incisor and also something with the molar, would a inferior nerve block suffice, or would you like to give an infiltration as well in the incisor region?
Yes. I think we should add on with
Yes.
A supplemental
infiltration
injection.
as a supplemental injection in the anterior region, especially in the central incisor
It
region.
may be required.
region. Yes.
And how many nodes need to be blocked effectively
Minimum
to
4.
achieve profound anesthesia.
We really can't have the microscopic vision.
Yes.
But yes, roughly about, if you are able to deposit the anesthetic solution closer to the nerve and cover about 8 to 10 millimeters of the nerve, then you are covering
yes.
3 to 4 nodes. So just to explain about the importance of this, generally we think that if one node is anesthetized, let's say you're giving a block here, you're giving an infiltration here, and this is one node. This is anesthetized. We think that then the subsequent, whatever that's beyond this node, is completely anesthetized. It never works like that. The impulse, whichever the sensory impulse, can actually skip from one node to the other. So it becomes very important that you anesthetize subsequent nodes. So which is the critical number is 3 to 4. And because we cannot see the nodes, the approximate length is 8 to 10 millimeters.
I think after the exhaustive lecture of Dr. Shenoy and also the discussion that we had, it's a great start to the lecture series of local anesthesia and dental practice. Thank you both so much for enlightening the participants and
Thank you,
about these topics. Thank you.
Thank you.